Hi everyone, today we're going to talk about morbidity and mortality. I'm Geraldine Cameron, your course instructor. First thing I'd like to talk about is surveillance, and there's a good definition from the CDC as to what surveillance is that you can see on this slide. But it involves ongoing systematic collection, analysis, and interpretation of health data. So surveillance really is surveying what diseases are ongoing, which ones are going up and down, for the purpose of better understanding what's happening so that if there needs to be public health programs, whether they be for prevention or treatment, those can happen as soon as they're needed. So there's different types of surveillance. There's passive surveillance and there's active surveillance. Passive surveillance is based on certain reportable diseases. Doctors in clinics and in hospitals are aware of which reportable diseases are out there in the United States, and when they come across a case of a reportable disease, they then are mandated to send that information to the public health department, who then will send it to the CDC. There's some reportable diseases that go directly to the CDC as well. And so passive surveillance really depends on the clinicians in the world to report the diseases that are coming through. There's also active surveillance, which is when a researcher or someone from the CDC comes out and actively surveys. And so that individual, that researcher, will go through the files of the patients, the patient records. They will talk directly to patients, they'll talk to the physicians, and they will actively pursue cases. They find a lot more this way because they're so focused on one certain disease and trying to find it. And so it takes a lot more people to do active surveillance. They'll find a lot more cases, and it ends up being a lot more money. So there's several conditions that are under regular surveillance. In this slide, there's just a few that are listed. So we might have some vector-borne diseases, waterborne, respiratory. All of these we might be able to take quick action if we see that there's an upswing in any of them. Vaccine preventable, if we see that something like measles starts to become more popular, well then the CDC or the Public Health Department will start pushing for vaccinations and making sure that people are up to date. There's some diseases that are hopefully soon to be eradicated, if not already eradicated, such as polio, and so even one case can cause quite the scurry of activity within a public health department because they are trying to totally eradicate polio. And then there's other conditions such as road traffic accidents or international problems like plague or unusual symptoms like some of these that are listed. And so surveillance really deals with measuring different diseases and how much disease there is within certain areas over time, and whether it goes up or down, and whether we need to have public health intervention at any certain point or not. The CDC has a list of reportable diseases. It's the National Notifiable Diseases Surveillance System, the NNDSS, and you can find this online to look at all of the different reportable diseases that are out there that physicians are mandated to report. This was started back in the 1870s, and this was authorized by Congress because there were certain diseases such as cholera, smallpox, plague, yellow fever, that if they even started going up in terms of numbers slightly, that the government wanted to know about it immediately so that they could institute quarantines. In 1902, the Congress then suggested that there's specific forms that needed to be used. And so really, I'm sure those forms, exact forms, aren't still used today, but physicians still do use forms, and many times they're electronic. And so what happens is when a patient comes in that has one of these diseases on the notifiable disease list, the physician then has to report to the public health department or directly to the CDC. The most commonly, or the most recently added, I should say, is the Zika virus, and that was added in 2016. All of these different diseases are then analyzed, the tracking is analyzed and placed in the MMWR, the Morbidity and Mortality Weekly Report, as research articles looking at the prevalence or incidence of disease over time to see what is increasing, what is decreasing, and that is put out, it's a publication put out by the CDC. So let's talk about morbidity. When we talk about morbidity, what that means is how much disease is there. So in this chart that you see, we're looking at the difference between diseases in 2007 versus 2013 in the Medicare population. And so we see that the top one, high blood pressure, has gone up a bit, but really what that's saying is that, from 2007 to 2013, high blood pressure has been about 50% of the population in Medicare, within the Medicare population. That's huge. And so even though high blood pressure is not a reportable disease, it still is very, very common. And so these common ailments or common diseases or disorders are also tracked because they are so common. When we talk about disease, there's two different ways that we typically describe it, either incidence or prevalence. Disease incidence is looking at the number of new cases divided by the number of people in the population who are at risk. And so we are only looking at newly diagnosed cases. And what incidence does is it helps us look at trends over time of the new disease. So how many new cases of let's say pneumonia or even cancer, how many new cases are there within the population? So we might say that there's 3 new headache cases out of 30 students who come into class for a given lecture for a 10% incidence in headache. There's also prevalence, and prevalence is the number of new and old cases divided by the number of people in the population who are at risk. And so this isn't just new cases, this is people who have had the disorder over time as well. And so if we're looking at something like heart disease or people who have high blood pressure, that could be a fairly large number because these conditions are very chronic. And so over time, as new people are being diagnosed, you add those to the current, the people who currently also are diagnosed, the old cases, we call them, and what happens is we see a much larger population of people who have the prevalence of disease versus the incidence, which is much smaller because it's only the new cases that are being diagnosed. So if we have 3 new headache cases plus 3 ongoing headache cases out of 30 students, we now have a 20% prevalence of headache. So prevalence really is equal to incidence times duration of disease. So the bigger the duration of disease, the bigger the prevalence. So if we look at incidence of breast cancer in the United States, we see that over time since the 70s it's been about the same. These are only the new cases that have happened over time, and we can look at the incidence of breast cancer at one given time point in different states so that we can look at which states have the highest incidence of new cases. And so during the time frame of 2008 to 2012, during that whole time frame, which states had the most new cases of breast cancer? When we look at prevalence of heart disease, we can see over time what is the burden of disease within the United States of heart disease. So you see here that heart disease was very, very common until about the 40s and 50s when it started to drop. Now it is still very common, but it's not as common. It's only about half as common as it was in the past. That's because Framingham cohort studies started in about the 40s, which we'll talk about in the future. And with the Framingham study, they started discovering the causes of heart disease, and they started implementing different programs in order to prevent heart disease, which is kind of a cool thing. So we look at prevalence to look at what is the burden of heart disease within the United States, the overall, not just newly diagnosed heart disease, but everyone who has it. And we can also look at this chart to look at which states have the highest prevalence of heart disease in those states. There's a couple different ways that we can look at prevalence. There's point prevalence and there's period prevalence. Point prevalence is looking at the number of cases divided by the population, but only at one point in time. So, for instance, we might ask a question of, do you currently smoke? It's only at one given time point. It's right now. Tell me if you smoke, yes or no. And so we're not asking, are you a new smoker or have you smoked for 30 years? We're really only interested in one point in time. Period prevalence, on the other hand, is how many cases are there divided by the total population over a whole period of time. And so have you smoked during the last 12 months? So of course with period prevalence we would see a much higher level of number of people who did smoke versus point prevalence, which is just at this one single point in time. So let's move on to mortality and talk a little bit about how do we measure mortality. We see in this list, this is the top causes of death in the United States in 2007. Heart disease was the #1 with cancer and stroke and COPD and unintentional injury following that. And this is for people, pretty much all people, not just adults, but children as well. But the numbers that you see under it are the actual counts of people who died. And so it's not a rate at all, it's an actual, just a number of deaths that occurred. But if we want to look at rates, what is the rate of death? Usually we'll look at mortality rates, which is the number of people who died divided by the number in the population. And that says usually at midpoint, meaning if we're looking over time, so let's say a 10-year span, the number in the population that we choose, because population goes up and down, would probably be the midpoint. And so how many people were there at the 5-year point? And so with mortality rate, we're really measuring how many people died. Now we can look at how many people died of a certain condition or just how many people died. So I have an example here. 50 people died from brain tumor divided by the number of people in the population. So this could be just 50 people died, or we look at condition specific, 50 people died from brain tumor, but the denominator is just the entire population. It's everybody. This is very different from case fatality rate, where we look at the number of people who died from a certain disease divided by the number of people who have that disease. And so with case fatality rate, again, it would be 50 people with brain tumor died, but our denominator, what we divide it by, would be 100 people with brain tumor. And so we're interested in knowing, of the people who have a condition, how many people died? Of the number of cases, how many were fatal? So case fatality rate. So these two rates are very different, and it's important for you to look at how is the denominator different in the two. And then we have proportionate mortality. Now what we're looking at is, of all the people who died, what proportion of that is due to a specific type of disorder that people died. And so we might look at 50 people with brain tumor died out of 5,000 people died. And so now we're looking at the denominator is of all of the people who died, what is and in the numerator we have number of people who died of a certain condition. And so these three rates are very different, but they all deal with mortality. It's very important that you can distinguish the three because they're very different. And one thing I want to talk about very quickly is the percent versus multipliers. So when we have a numerator and a denominator, we certainly can express that as a percent, and in some cases it is expressed as a percent. Like if we're talking about proportionate mortality, we might say 40% of those who died from blah blah blah. But we also might want to have a multiplier, and so instead of saying 0.1% of people have this disease, we might say 0.1 out of 100 people have it. But it doesn't really make sense to say 0.1 person. What is a 0.1 person? That's not a real thing. So, is it somebody's leg? No, I'm kidding. So what we want to do is to be able to have whole numbers of people. So we want to say 1 out of 1,000 instead of 0.1 out of 100. Or we might want to say 10 out of 10,000 or 100 out of 100,000. And so we have to be able to go back and forth between these different types of multipliers because we say different ways for different purposes. They're not different. They all mean the same thing, but the way they're expressed is different. And sometimes when we're looking at several different disorders, we want them all to be out of maybe 100,000 people so that it's easy for us to compare one disease to another. Let's say the incidence of one disease to the incidence of another. Finally, I'd like to talk about natural history of disease. This is how the disease looks over time. So natural history of disease is looking at disease from the inception until either complete recovery or death. I really like this timeline. We might think about skin cancer. So when people are laying out in the sun, they are susceptible to it. They have an exposure. And at some point, people who get skin cancer, they have a pathologic change. So something happens within their cells that suddenly becomes pathologic. It becomes bad. And this is the initial stage of subclinical disease. But usually they have no idea until they start seeing some sort of change on their skin. They might see that it's discolored, or it might itch or be painful or have other symptoms. And at that point, they might then seek treatment and a diagnosis is made. And now there's stages of clinical disease. And then that continues on until disability or death, or complete recovery, such as they might have the cancer removed. And so this is how disease goes throughout the course, the history of that disease within each individual. The interesting thing is when we think of inception of disease, when does it start? We really don't know, because we can't tell that one or two cells have suddenly become pathologic. And so it's one of those things where we really can't define it until there is a diagnosis. And so coming up with better and better diagnostic capabilities becomes even more important over time because we can diagnose these diseases faster. Which brings me to the iceberg theory of disease. This thought is that really we only see a small fraction of disease at any given time point because there is so much preclinical or subclinical disease. And so the preclinical would all be under the water of this iceberg. It's all that we cannot see, whereas the above the water iceberg is what is getting diagnosed. Sometimes when we think about new ways to diagnose, such as when we shifted from mammogram to breast MRI, it's like shifting the water level down. Suddenly we can see many more cases of whatever disorder we're looking at, in this case breast cancer. And it doesn't mean that there's so many more cases, it just means so many more cases were diagnosed. So finally, I'd like to just wrap up by saying when we look at public health and all that public health departments do, this is a good way to look at the approach. So it starts with surveillance, really better understanding how many people have a certain disorder, how has it spread, which communities have the highest prevalence of a disorder or even incidence of a disorder, and so understanding what the problem is. And then taking the next step to understand why do people get this disease, and really getting more into the cause of the disease or the risk factors of the disease. And then taking the next step of, well, now how do we either prevent it or treat it? Certain types of interventions, and trying to understand, well, what works so that we can try and kind of rein it in and decrease the incidence of the disease. The last step is implementation. This deals more with public policy. And so, as I've said in the past, public policy is a very big part of public health, and that's because without the policy, without understanding implementation practice, we won't get very far, because until we get out in the community and figure out how can we either prevent disease or treat disease, people will continue having it. So if you have any questions, please feel free to let me know. Thank you.